Thank you very much from Clarinet. And I welcome all of you to our program of E-Gurukul Pathshala PG Clinic. This time we are coming with the new concept of seminar. And for this, we are having this time and we are thankful to the Department of Pediatrics, BJ Government Medical College and Sassoon General Hospital, Pune to take this initiative. And for this program, as we all know, we have our convener, Dr. Baldev Prajapati sir, always with us to guide us. And this project in charge, Dr. Yogesh Parikh sir. Sir, welcome, and a few words from you.
Thank you very much, Dr. Nehal madam. We welcome all the participants, presenter and the mentor of BJMC Pune and the Sassoon Hospital, Pune, for this wonderful congenital anomalies of genito urinary tract and clinical implications seminar. This is the first kind of seminar in our E-Gurukul Pathshala program. And congratulations in advance to all presenters and the mentor. We welcome Dr. Dasmeet Singh, President of Indian Association of Pediatric Surgeons, who is also from the BGMC Pune, and our project coordinator, Dr. Aarti Kinikar madam and Dr. Vaishali Joshi madam. So let us start the program with the introduction. Thank you very much.
Thank you very much, sir. So I hand over the program to Aarti Kinikar madam. Madam, please go ahead.
Thank you, Dr. Nehal. Thanks, Dr. Yogesh sir, for giving us this opportunity to present. And I'll start with introducing my colleague and a very good friend, Dr. Dasmeet Singh. He is a well-known pediatric surgeon, not only in the city of Pune and the state, but all over the country. And presently, he is the president of the Indian Association of Pediatric Surgeons. He is an alumni of BJ Government Medical College, Pune, where he has done his undergraduation and also his post-graduation, and his super specialty was done in Grand Medical College, Mumbai. That's where I met sir a long time ago. It's been over 30 years now. He's into pediatric surgery. And he has been instrumental in being the first one to initiate many things in pediatric surgery, including the laparoscopy, thoracoscopy. And what is the beauty about him and his practices, that he has always been attached to his alumni, which is a government medical college where the poor people are getting the surgeries done with his expertise. He has many national and international publications to his credit, as well as he has held various positions of repute in the branch of pediatric surgery. And he has another aspect to his, not just being a pediatric surgeon, but a lot of CSR activity. He has been involved and working for the needy and the patients through two things. One, he is an excellent drummer, and he's a part of the Medicos orchestra from BJ Medical College, and they do a lot of programs for patient care and raise funds. And he's been doing it with his groom, and also Dr. Shailusha is one of the presenters, a very good singer, is a part of that orchestra. So at the end of it, you want to listen from her, we will request her to do that. And other thing about Dasmeet, I would like to say that he is often called when there is a complicated surgery, be it a private hospital, be it AFMC, wherever on table, if there is a complication, he runs over there. And I'm very fortunate to be associated with him for so many years. And I welcome you, and I really thank you for finding time in your busy schedule to be with our students and also E-Gurukul platform and share your expertise about the field of expertise of Dr. Dasmeet is urogenital pediatric surgery, congenital anomalies. So I think you are the right person for it. So welcome, Dr. Dasmeet Singh. Next
Thank you.
is our mentor, Dr. Pragati Kamath. She's a senior associate professor associated with BJ Medical College. First as a postgraduate student over here and now as a associate professor. Very academic, very strict also, but also very helpful to the students. And she has guided the four presenters who will be presenting their first seminar. It is Dr. Nehal has already told that. And when I see Dr. Baldev Prajapati, sir, I need to stop here and welcome you, sir. Without you, this program cannot go ahead. And we need your clinical inputs definitely. So Dr. Pragati, welcome to this program and see how your mentees are doing today. Okay.
Thank you. Thank you.
And then we have the four presenters. Since it's a seminar, we thought we will divide the topic into four residents so that four residents get a chance to interact with Dr. Prajapati sir, Dr. Nehal, Dr. Yogesh, Dasmit, and all the people who are watching this program. So we'll be starting the program with Dr. Shailusha, who is the third year resident. They have just finished submitting their thesis and now they are getting ready to appear for the exam. Next will be Dr. Ketki, who is also a junior resident JR3, followed by Dr. Jaya, JR3 resident, and Dr. Apurva, JR3. They all are work together. They have done some rehearsals. If there are any issues, I think I and Dr. Pragati will take the blame for it. Okay, but I know they will do their best. You seniors are always there to guide. And at the end, Dr. Dasmit Singh can tell us about the pediatric surgery interventions, which will definitely help the residents. So thank you. I will hand it over. Dr. Prajapati sir, would you like to say a few words before we start? Because we are doing it for the first time. Students are used to case presentations and today we are doing a seminar.
So I think always innovations are good. Anywhere we should go for the innovations. And definitely we can learn from the innovations. If requires even further, we can go for the modifications. But I will appreciate that this is a good idea. And definitely we'll see that how it works. Or definitely I'm confident that it is going to work in a best way. Because multiple students will get the opportunity. Thank you very much, madam. I think we can go ahead.
Yes. Dr. Shailusha, can you take over and start with your presentation, please?
Good evening, respected faculty. I am Dr. Shailusha Vadapalli, third year resident at BJ Medical College in Sassoon Hospital, Pune at the Department of Pediatrics. I will be starting the seminar with the development and anomalies of the kidney. The evolution of the kidney follows the principle of autogeny repeats phylogeny. The beginning of development of the urinary system is in the 4th week of intrauterine life. And the urinary system develops from the intermediate mesoderm and the primitive cloaca. There are 3 evolutionary stages of the developing kidney, namely the pronephros, mesonephros, and metanephros. The pronephros and mesonephros, which develop in the 4th and the 5th week of intrauterine life respectively, do not persist in the final development in mammals. The only remnant, the final persistent element of the evolutionary element is the metanephros, which develops in the sacral region of the embryo during the 3rd month of intrauterine life, and its duct, which forms the drainage system of the kidney, is the ureter. Coming to the anomalies, renal agenesis. Bilateral renal agenesis is incompatible with life. These babies are generally stillborn or succumb in the perinatal period. On the antenatal scans, they present with severe oligohydramnios and lung hypoplasia. They present with Potter's syndrome with wide-set eyes, downturned nose, low-set ears, facial skin creases, generally breech presentations, and with limb anomalies. Usually diagnosed at 12 weeks, one should advise an MTP if this is antenatally diagnosed. Once diagnosed in one pregnancy, there is about 5% risk of recurrence in the subsequent pregnancies. A lesser severe variety is a unilateral renal agenesis. It is generally asymptomatic and the prognosis depends on the function of the contralateral kidney. This condition is associated with other anomalies, mainly the Vactidal group. The presentation is more common in male babies than in females. The incidence is around 0.1 to 0.2% of all live births. These babies, if antenatally diagnosed or when picked up incidentally in postnatal period, should be followed up 6 monthly with blood pressure monitoring. Urine routine and protein creat ratio should be done annually. Blood urea and creatinine should be examined annually. These babies need regular USG, kidney, ureter, bladder. An MCU is required to detect lower urinary tract anomalies involving the contralateral kidney. A DTPA scan is useful to assess the function of the solitary kidney. When there is associated proteinuria and hypertension, the recommended treatment is with ACE inhibitors and angiotensin receptor blockers. The kidney develops in the sacral region and ascends to the thoracolumbar region to the level of T12 to L3 level by about 9th week of intrauterine life. This ascent is due to the differential growth of posterior abdominal wall and the folding of the embryo. A failure of normal ascent of the kidney results in ectopic kidney, most common location being the pelvis opposite the sacrum at the level of aortic bifurcation. The ectopia can be simple or could be crossed ectopia. Crossed ectopia is most common on the right side, in which the left kidney crosses over to the right side. The clinical implication of this condition is that in case there is a surgery required on this kidney, the blood supply is generally aberrant and may lead to excessive bleeding intraoperatively. The next anomaly is a horseshoe kidney. This is the most common fusion anomaly of the kidney, in which the lower poles are joined to form an isthmus, which could be or may not be functional. The incidence is around 1 in 1400 to 1800 live births. The isthmus is normally at the level of L4, L5 level at the level of inferior mesenteric artery. 30% of these cases are associated with vesicoureteric reflux. It is commonly associated with congenital genetic disorders like trisomy 18 Turner syndrome. It is associated with Wilms tumor, and this fusion of the two kidneys is anterior, and this makes the kidney susceptible to trauma. The recommended follow-up of horseshoe kidney is a monitoring of blood pressure and ultrasound examination at annual intervals. Next is renal dysplasia, which could be total dysplasia or subtotal dysplasia. Total dysplasia results in a functionless, atretic, or absent kidney. This situation again is incompatible with life if it is a bilateral complete dysplasia. Unilateral dysplasia is again asymptomatic and it gets diagnosed only on an ultrasound. Prognosis depends on the contralateral kidney, which generally has associations with vesicoureteric reflux, hydronephrosis, and stones. Prognosis again depends on the function of the contralateral kidney. Total dysplasia goes undetected on a DTPA scan, which is a functional scan. It requires CT evaluation or an ultrasound examination. Subtotal dysplasia, on the other hand, has a variable function of the kidney on a DTPA scan. This kind of a kidney is at risk for urinary tract infections. It presents in childhood with systemic hypertension, and the severity depends on the degree of tissue dysplasia. The treatment involves treatment of the complications. A partial or a total nephrectomy may be needed. Next is a medullary sponge kidney. Incidence being 1 in 5,000 to 20,000 live births. This condition rarely gets diagnosed in childhood. This is not particularly a pediatric presentation. Generally, the presentation is in the adolescence or early adulthood. It is associated with a number of syndromes like Marfan syndrome, Ehlers-Danlos syndrome, Beckwith-Weidman syndrome. Presentation is generally with hematuria, UTI, and it gets confused with renal calculi. It runs a benign course, generally does not cause progressive renal failure. So the treatment is mainly management of complications, that is calculi, UTI, and others. On an ultrasound examination, medullary sponge kidney has increased hyperechogenicity of the renal medulla. A common differential diagnosis is nephrocalcinosis. On intravenous urography, there is a paintbrush-like appearance. And on an axial CT, again, brush-like densities are seen in bilateral renal papillae. Next anomaly is a multicystic dysplastic kidney. It is the most common cystic disease of the kidneys with an incidence of 1 in 4,300 live births. It is generally unilateral. Differential diagnoses include hydronephrosis, Wilms tumor, and renal vein thrombosis. It is associated with maternal illnesses like maternal diabetes, intake of anti-epileptic drugs. On the USG and CT examination, the renal tissue is replaced with cysts of various sizes that do not communicate with each other. Around 30% cases are associated with pelviureteric junction obstruction, and around 10% are associated with higher grades of VUR, that is grade 3 and grade 4. All cases of multicystic dysplastic kidney should undergo a DTPA scan. The risk of hypertension and malignancy is very low in this condition. Surgery is required only if there is obstructive uropathy. Another similar commonly confused condition is polycystic kidney disease. Polycystic kidney has two variants, autosomal recessive polycystic kidney and autosomal dominant polycystic kidney. Autosomal recessive polycystic kidney disease is a bilateral illness associated with other illnesses like congenital hepatic fibrosis, biliary dysgenesis. The presentation is a flank mass with hypertension, hematuria. It progresses to end-stage kidney disease in childhood. Autosomal dominant polycystic kidney disease, on the other hand, is the most common inherited disease of the kidney. There are progressive kidney cysts presenting in childhood to adolescence. A very small subset presents in infancy. It progresses to chronic kidney disease with hypertension. This is also associated with liver cysts and cerebral aneurysms. Common confusion between the multicystic dysplastic kidney and polycystic kidney, which we have encountered among exam-going students. Multicystic dysplastic kidney has very little normal functional parenchyma, and it is generally a bilateral, it is a unilateral disease, most commonly seen on the left side. Polycystic kidney disease, on the other hand, has multiple cysts, but there are varying proportions of viable renal tissue between the multiple cysts. This is generally a bilateral condition. Urological anomalies are commonly diagnosed on antenatal scans. In about 1 to 2 per 1,000 live births, an antenatal scan shows some kind of a urological anomaly. 80% of the neonates who have an antenatally diagnosed urological anomaly are generally asymptomatic. The amniotic fluid is a very good indicator of renal function. Poor renal function leads to less urine output in the fetus, leading to oligohydramnios, which further leads to lung hypoplasia because of poor fetal lung expansion. These babies generally present with respiratory distress in the neonatal period, and respiratory distress or oligohydramnios known on an antenatal scan indicates a poor fetal and neonatal outcome. Urine output in the fetal kidney begins at 13 weeks. Therefore, the urinary bladder should get visualized by 15 weeks. In case the bladder is not visualized till 15 weeks, this is considered abnormal. Fetal hydronephrosis. This is one of the most commonly diagnosed antenatal renal anomalies on an antenatal scan. Around 1 to 5% of all pregnancies get diagnosed during the second trimester. The antenatal scan showing the AP diameter of the renal pelvis classifies the fetal hydronephrosis into mild, moderate, and severe varieties. The mild hydronephrosis will have an AP diameter of renal pelvis between 4 to 7 millimeters in the second trimester, 7 to 9 millimeters in the third trimester. Moderate hydronephrosis is defined as 7 to 10 millimeters AP diameter of the renal pelvis in the second trimester, 9 to 15 millimeters in the third trimester. Severe hydronephrosis in the second trimester will have more than 10 millimeters of renal pelvis diameter and more than 15 millimeters of renal pelvis dilatation in the third trimester. Mild pelvic dilatation could be a normal variant. It just needs to be followed up. Sometimes it is associated with Down syndrome. Bilateral hydronephrosis and hydroureter associated with oligohydramnios indicates a poor outcome. Whenever there is hydronephrosis, obstructive uropathy needs to be ruled out, especially in male babies in whom we should suspect posterior urethral valves. The Society for Fetal Urology classifies hydronephrosis into 5 classes. Grade 0, in which there is no splitting of the renal pelvis and the parenchyma is normal. Grade 1, which has mild splitting of the renal pelvis with normal renal parenchyma. Grade 2, with moderate splitting confined to the renal border with normal parenchyma. Grade 3, marked splitting of the renal pelvis, including calyceal dilatation. In this stage, also the renal parenchyma remains normal. Grade 4 is with pelvic calyceal dilatation, and in this, the renal parenchyma is thinned out. The differential diagnosis of antenatally diagnosed hydronephrosis includes majorly non-obstructive pelvic dilatation, PUJ obstruction, and vesicoureteric reflux. Other less commonly seen entities are megaureters, ureteroceles, renal cysts, ectopic ureters, and PU valves. The question is, when do we consider an MCU in a neonate? The indications are bilateral hydronephrosis, duplex kidney, ureteroceles, and thickened bladder wall or ureters. This is a flow chart that is recommended to be followed in case there is an antenatally diagnosed hydronephrosis. It is particularly useful in the postnatal evaluation, particularly in the labor room postings. When there is an antenatally diagnosed hydronephrosis, a postnatal ultrasound is recommended in the first week of life. It is generally done at 4th to 5th day once diuresis has begun and the kidney has started to produce urine. However, if the baby is sick, septic, or anuric, it can be done earlier. If the first week ultrasound reveals no hydronephrosis, this baby needs to be followed up with an ultrasound at 1 month again, and at 6 months and at 1 year till 5 years of age annually. The follow-up is these babies require follow-up only. In case the first week ultrasound reveals a unilateral hydronephrosis, which is usually asymptomatic, then depending on the grades, the SFU grading of the hydronephrosis, the management is different. For grade 1 and 2 hydronephrosis, generally ultrasound monitoring is the only requirement. Grade 3 and grade 4 hydronephrosis requires an ultrasound, a radionucleotide study, that is a DTPA scan, and an MCU. In case a bilateral hydronephrosis or a solitary kidney is detected on the postnatal scan, an MCU is required early, a radionucleotide study is needed, and the time when we should ideally involve the surgery team is when the renal function starts to deteriorate, if there is an increasing pelvic diameter, or in case there is bilateral PUJ obstruction. The take-home message from here is that even if there is a normal scan in the first week following an antenatally diagnosed hydronephrosis, follow-up needs to be done till 5 years of age. No matter the renal function or the findings on the postnatal scan. Even if there is no finding on the postnatal scan, the child needs to be followed up till 5 years of age. I would now hand over to Dr. Ketki, my colleague.
Thank you, Shailusha. Dr. Dasmit, can we finish their presentations and then come to you? Is it okay?
I think that makes sense.
Okay.
It was excellently presented by Silusha. I'm sure the others also going to do a great job. So they're not leaving too many doubts. But if there are any doubts, I think people should put them up in the chat box and we will try and answer them. Only thing, somebody will have to keep a tab of the chat box of the delegates.
Yeah, I'll do that.
Yeah.
So I'll just request the students who are listening to put their queries in chat box. So we have tried to cover the anomalies with 4 presentations, and still you have any doubts, please write it in the chat box. Yeah, over to you, Dr. Ketki.
Good evening, everyone. Now that kidney is covered, we will be discussing about development and anomalies of ureter and urinary bladder. One slide about development. From here, the ureteric bud is the one which will help in the formation of ureter, and that is the collecting system of the urinary tract. The ureteric bud, when condenses with the metanephros, it leads to the formation of metanephric cap. So in the second image, the metanephric cap is the one which will be forming the secretory portion, that is the nephron, and the ureteric bud further divides and it has subdivisions. Then it forms the calyces, pelvis of the ureter itself. Now, what forms the urinary bladder? The cloaca, which is the terminal part of the hindgut, is divided by the septum into primitive urogenital sinus and the primitive rectum. In the right image, in the B diagram, in C, we can see that the primitive urogenital sinus divides into vesico-urethral canal and definitive urogenital sinus. It is the vesico-urethral canal which later on forms the urinary bladder. The proximal dilated part of the vesico-urethral canal forms the urinary bladder, and the lower narrowed part then helps in the formation of the urethra. In the lowermost diagram, we can see that the trigon, and in the last diagram, the trigon and the posterior wall of the starting of part of the urethra is formed due to the condensation of the mesonephric duct. Now, discussing about the anomalies of the ureter. Firstly, we will discuss about the pelvic ureteral junction obstruction. It is the most common obstructive lesion in childhood, which can lead to hydronephrosis as shown in the picture. The most common cause being the intrinsic stenosis. Also, it can be caused due to some extrinsic compression, like due to some vessels. Left side being more common in male than female, and 10% of the cases can be bilateral too. So, how can we diagnose it? It may be diagnosed on the antenatal scan due to an asymptomatic dilation of the renal pelvis, or it can present with a palpable renal mass or urinary tract infection. So on evaluation, the intravenous pyelography will show that there is delay in the appearance of the contrast, and the pelvis and the calyces are dilated. It is managed by pyeloplasty, and surgery is indicated if the infant presents with abdominal mass and there is severe bilateral hydronephrosis, or there is a solitary kidney, or there is decrease in function of the involved kidney. Next is ureterocele. Ureterocele, as shown in the diagram, it is the cystic dilation of the terminal ureter. It is often associated with the duplex system, in which mostly the upper moiety ureter is usually associated with the ureterocele. Simple ureterocele is the one which is orthotopic, that is, its opening will be normally, that is in the normal place, that is trigon. But if but mostly the site of obstruction is usually ectopic, that is not opening in the trigon. So how can it present? It can present in the antenatal scan, or as a urinary tract infection, or an incidental diagnosis. Like on intravenous urography, we get a cobra head sign. What are the complications of ureterocele? It can cause the bladder outlet obstruction, or it can cause vesico-ureteric reflux. So due to obstruction, it can cause the reflux on the contralateral side, or any obstruction can cause urinary retention, resulting into the hydronephrosis. So management being endoscopic de-roofing, but if it is associated with severe bladder outlet obstruction, then excision and reimplantation may be indicated. We have then the next anomaly is the double ureter. As shown in the middle diagram, the upper moiety ureter, as discussed in the duplex ureter, is associated with the ureterocele, and the lower moiety ureter is usually associated with the
of vesico-ureteric reflux. So this is the Wiegand-Mayer law. In case of double ureter, it may or may not be associated with the double kidneys, or it can be associated with duplication of the other urinary tract also. But most commonly, doubling of the urinary tract involves majorly ureter. Then next is the ectopic ureter. As discussed earlier, ureter drains outside the bladder and it needs reimplantation. Then one thing, we have the retrocaval ureter. As the name suggests, the ureter is behind the inferior vena cava. So we have the typical J sign or Fishhook sign, and it also presents with obstruction followed by hydronephrosis, needs a surgical intervention. Next, we have mega ureter. It is more common in males and it is more common on the left side. So primary mega ureter, it happens when there is problem with the peristalsis in the ureter. Secondarily, it can happen due to high-grade vesico-ureteric reflux or bladder outlet obstruction, neuropathic bladder, or in Poon-Bailey syndrome. So how does it present? It presents with the urinary tract infection or a groin pain or stones or hematuria. It needs excision and reimplantation. Now, short about Poon-Bailey syndrome, as it is also called as the Eagle-Barrett syndrome. As shown in the diagram, it is associated with the triad of deficient abdominal muscles, plus undescended testis, plus urinary tract anomalies. Also, in 50% of the cases, it will be associated with some cardiac anomalies or musculoskeletal anomalies. Now, vesico-ureteric reflux, as evident, it is a retrograde flow of urine from bladder to ureter of kidney and cause being short or absent submucosal tunnel. Submucosal tunnel, when it is oblique, it prevents the reflux, but when this obliquity decreases, it leads to the reflux. So mostly, it is the primary vesico-ureteric reflux, which mostly is the autosomal dominant. How can it present? The reflux mostly present with the urinary tract infection or antenatally with the hydronephrosis or bladder bowel dysfunction, renal insufficiency, or in advanced cases, it can present with hypertension. Complications, reflux nephropathy. So reflux nephropathy, which further may go to renal scarring, and renal scarring is the one which may progress towards the chronic kidney disease later on. Other complication being megacystis, mega-ureter syndrome. So management, we will discuss it later. It needs antibiotic prophylaxis, and lower grades may resolve by 6 years of age, but higher grades, more than 3, require surgical intervention in the form of reimplantation or endoscopic injections. The grading of the vesico-ureteric reflux is done based on the Mecheliting cystourethrogram, based on international reflux study grading, in which the grade 1, we have vesico-ureteric reflux into the non-dilated ureter, as shown in the first image. In the second image, we have the reflux in the upper collecting system too, but there is no dilation. In third, we have reflux in the dilated ureter along with some blunting of the calyceal fornices. In the fourth diagram, we can see there is some grossly dilated ureter, reflux into the grossly dilated ureter, and the tortuosity has already started. And in grade 5, we can see it is massive vesico-ureteric reflux with significant ureteral dilation with tortuosity, and there is loss of papillary infiltration too. Now we can see, now we have discussed about ureter, now about the anomalies of the urinary bladder. In urinary bladder, we have the urinary bladder diverticula. It occurs due to herniation of the bladder mucosa in between the smooth muscle fibers of the bladder. Now diverticula can develop anywhere in the bladder, but specific mention needed when the bladder is in, when the diverticula is in the neck, then it can cause obstruction. So it needs excision. And when the diverticula occurs paraureteric, then it can cause reflux, like the vesico-ureteric reflux, and it needs ureteric reimplantation. Like shown in the diagram, we have a diverticulum with the reflux, vesico-ureteric reflux. It is the paraureteral diverticulum. Extrophy of the bladder. Extrophy of the bladder results when mesoderm fails to invade the cephalad extension of the cloacal membrane. As shown in the image, we have the classic bladder extrophy in a newborn male. Bladder is exposed in the midline, umbilical cord though not seen, it is displaced corded, penis is epispadiatic, and the scrotum is broad. Also, the pubic rami are widely separated, and the child has a broad gait. The management being at birth, we can cover it with plastic wrap. Latex is avoided. The two surgical approaches which are shown is the staged or the single stage. So as evident from the name, staged means it is done in 3 stages. Like bladder closure is done within 48 hours of life. And then we do the episperiasis referral, which is done nearly at 1 to 2 years of life. Then we creation of bladder sphincter is done, which is done nearly at 3 to 6 years of life, so that there is no incontinence. These 3 repair can be done as a single stage in the single stage reconstruction. Complication of exstrophy of bladder will be urinary incontinence, and it increases the risk of bladder cancer, mostly adenocarcinoma. Now we will discuss about urachal anomalies. As shown in the diagram, patent urachus or urachal fistula in the third C diagram, it may be isolated or associated with Poon-Belly syndrome or PUV, posterior urethral wall, and it will present with a continuous dribbling of urine through the umbilicus, and the tract needs to be excised. Then next we have urachal cyst in the D image. It presents with the suprapubic pain, fever, irritative voiding symptoms, and infraumbilical mass. And treatment is IV, antibiotics, and drainage and excision. The other anomalies are vesicourachal diverticulum and the umbilical urachal sinus, which is shown in A and B respectively, and they also need the excision. I'll call over Apurva for the rest of the presentation.
Thank you, Dr. Ketki. Dr. Apurva, can you take over?
Evening, everyone. I would now like to proceed with urinary tract infection prophylaxis and a few points on female genital tract. So coming to UTI, the basic definition of UTI. For diagnosis of UTI, we need symptoms as well as it is supported by laboratory evidence. In symptoms, we have the common symptoms of fever, dysuria, urgency, frequency, abdominal pain. In infants, it can have slightly non-specific presentation like vomiting, diarrhea, poor weight gain, because of which they can also present as failure to thrive. Along with these symptoms, we have laboratory evidence also. So first thing will be a urine dipstick test, which is a very simple screening tool. It will show the presence of leukocytes and nitrites. Second is urine routine microscopy, which will show significant pyuria and bacteria. And lastly, urine culture. Urine culture is the gold standard. It will show a specific microorganism and will also help us in starting the particular antibiotic. Now, there's also an entity called asymptomatic bacteriuria. It basically means that there is significant bacteria, but there's an absence of symptoms, and it is more common in girls, and is associated with the non-virulent strains of E. coli. Now, since it is non-virulent, we need not worry much about this, and there's no need to rush with starting antibiotics in this case. Coming to approach to UTI, first we classify UTI as complicated and uncomplicated. So in complicated UTI, what exactly is complicated UTI? So any form of UTI, but if the age of the child is less than 3 months old, we are going to consider it as complicated. Or otherwise, the child will have a more serious kind of presentation where he'll have high-grade fever, he'll be sick-looking, toxic, dehydrated, might not be accepting feeds. And lab-wise, your RFTs will be deranged, the creat levels will be high. And UTI in which the causative organism is something other than E. coli. E. coli is the most common cause of UTI, but we also have other organisms like Proteus, Klebsiella, Pseudomonas. So in those cases, we need to be more worried and will consider it as complicated UTI. In complicated UTI, any child will admit the child, will start IV fluids and will start IV antibiotics. And after 48 hours, you have to reassess the child. Now, by that time, if your urine culture report has come, you can change the antibiotic according to the culture report. Also, if there is clinical improvement, then it is a good sign, and you can even switch over to oral antibiotics. And the total duration of antibiotics has to be 10 to 14 days. Another important point here is that we are going to aim for symptomatic improvement, and we are not going to be after the urine culture report. There's no need to repeat a urine culture if good clinical response is noted. This was about complicated UTI. Uncomplicated UTI is more than 3 months old child, and he's a well-looking child. He's accepting well orally. He's not toxic. Uncomplicated UTI, there's no need to admit the child to start oral antibiotics, but you make sure to call them after 48 hours and you reassess the child. If there is clinical improvement, then good. You continue the same treatment for 7 to 10 days. Again, here there's no need to repeat a urine culture. Now, once the child has been diagnosed with UTI, there's further follow-up or evaluation. So if any child, like in infants less than 1 year, first of all, a child has come with UTI, a baseline test which has to be done is ultrasound. In all the age groups, we are going to go for an ultrasound. In age less than 1 year, along with ultrasound, we're also going to do renal scan, that is DMSA scan and MCU. Now, important, the time of the scan is after 4 to 6 months after the UTI episode, because during UTI, our kidneys are inflamed, and so the uptake of the dye is going to be good, and it can yield false negative results. That's why we'll wait for the UTI to resolve, and after 4 to 6 months, we'll do the scan or MCU. So in less than 1 year, we're going to do all the three things. 1 to 5 years, we'll do the ultrasound and renal scan, and only if the renal scan is abnormal, we'll go for MCU. And more than 5 years, just do the ultrasound first. Only if the ultrasound is abnormal, you go for the other two tests. Now, what recurrent UTI is? 2 episodes of UTI. So more than 1 episode of UTI, we're going to consider as recurrent UTI. So in case of recurrent UTI, or first episode of UTI in a child less than 6 months, or presence of known risk factors like these congenital anomalies, which has been discussed earlier, we are going to involve a pediatric nephrologist here, and then we are going to discuss about antibiotic prophylaxis. So so these are the guidelines given by the Urologic Society of India. They were published in 2019. So when to give antibiotic prophylaxis. So these guidelines say that in all infants less than 1 year old, definitely you go for antibiotic prophylaxis. Or while awaiting imaging studies, like we saw in the previous flowchart, we have done MCU, and the MCU report is awaited. So till you get the report, you can start antibiotic prophylaxis. Other thing is vesico-ureteric reflux. So in less than 2-year-old child, irrespective of the grade, we are going to start antibiotics. Whereas in 2 to 5 years, grade 3 to 5, we'll start antibiotic prophylaxis, because as discussed earlier, these are the grades which are like they are going to require surgical intervention. And also 3 or more episodes of UTI in the year, you go for antibiotic prophylaxis. The duration of antibiotic prophylaxis is not fixed. It will be individualized depending on the presentation. But generally for grade 3 to 5, we go for a period of 3 to 5 years of prophylactic antibiotics. So it is like long-term prophylactic antibiotics. Next, when can we defer? That is, we can wait and watch or individualized approach regarding antibiotic prophylaxis. So like in infants, as we discussed, we need to give antibiotic prophylaxis. But more than 1-year-old child, first episode of UTI, no need to start antibiotic prophylaxis. Have a second UTI, that will be a recurrent episode of UTI, so you will need prophylaxis. Like causes of urinary tract obstruction, like posterior urethral walls, urolithiasis, neurogenic bladder, to address the primary cause first. And also asymptomatic bacteria, like we discussed earlier, you don't need to start prophylactic antibiotics right away. Now, these are few scenarios like when to plan antibiotic prophylaxis. So this will be like, it will be a multidisciplinary approach. You will need a pediatric nephrologist, a pediatric surgeon, and then plan. So complex congenital anomalies of kidney and urinary tract, or with underlying bladder dysfunction. These guidelines are actually by the Swiss Consensus Guidelines published in 2020. So what these guidelines say that grade 4 and 5 VUR, vesico-ureteric reflux, so definitely give antibiotic prophylaxis. But grade 3, you can wait. It will be depending on the case, like depending on the presentation, individualized approach is needed in case of grade 3. Also, if MCU is indicated, antibiotic prophylaxis may be started, and you continue it till the time of examination, until the report is awaited. The choice of antibiotic for prophylaxis is trimethoprim, if available as single substance. And also amoxicillin is a good antibiotic, especially in simple uncomplicated UTI. We can go for amoxicillin. So discussing further the antibiotic options. When you have admitted a child and you're starting him on antibiotics, so if you're going for oral antibiotics, then cefixime is a very good drug. It is broad spectrum. The dose is 10 mg a day. You have to give it BD. Other options are amoxicillin, amoxicillin, and even cefalexin. If the child is admitted in case of IV antibiotics, we can go for aminoglycoside, amikacin and gentamicin, or third generation cephalosporin like cefotex and ceftriaxone. And for prophylaxis, we commonly use Septran, that is a combination of trimethoprim and cotrimoxazole. Other options also nitrofurantoin. The doses have been given in this slide. Next, coming to follow-up. So you have treated UTI, you have discharged the child. So during treatment, this is an important point that we are not going to run behind a negative urine culture report. We aim for symptomatic improvement, like the overall well-being of the child should improve, the fever should resolve, the symptoms should resolve. And yeah, you are going to call him for follow-up. So these are the 5 things which you will do during follow-up. First is you're going to assess the growth, because like I mentioned earlier, recurrent UTI can also present as failure to weight gain and failure to thrive. So growth assessment is important. Secondly, if he's having another febrile episode in the future, and you know he has had a history of UTI in the past. So when you're doing his test, you always make sure to do a urine routine. And blood pressure evaluation 6 to 12 monthly. Then renal function once a year. So we are going to look for the urea and creat levels, especially if the child had a severe UTI in the past. Because these children are prone to, again, like if they are dealing RFTs plus congenital anomalies, they are prone to develop CKD in the future. And also proteinuria, because recurrent urea, the kidney will get scarred, especially pyelonephritis, which is a more serious form of urea. It's going to be renal scarring, which will lead to proteinuria. So you can go for a urine dipstick and you can look for the presence of proteins. This is the follow-up of UTI. Next, I'll be talking about the genital system. So coming to the genital system, we have the gonads, that is the testis and the ovary. Then the duct system, the mesonephric duct and the paramesonephric duct and the external genitalia. Now in the fetal life, in the first 6 weeks of fetal life, we cannot differentiate between a male and female fetus. At 12th week, we can start differentiating on the basis of external genitalia. And at 20th week, there's complete phenotypic differentiation. It can be distinguished. So the basic development of genital system is from the intermediate mesoderm, a part of cloaca, and the coelomic epithelium, which covers the intermediate mesoderm. Now coming to the development of uterus and vagina. So in females, we have the paramesonephric ducts, which give rise to the uterus, the fallopian tubes, and the upper part of vagina. So in vagina, the development of vagina is, as we can see here, there's something called a vaginal plate. So the development of vagina is from two different sources. The upper part of vagina, that is the vaginal fornices, and the upper part of the vagina, it comes from the uterovaginal canal. Whereas the lower part comes from the sinovaginal bulge, which is actually derived from the urogenital sinus. So and they together form the vaginal plate. And later on, at the lower end, there's a small opening which we can see that is going to be the hymen. So important here is that the vagina, it develops from the mesoderm as well as the endoderm. The upper part is developing from the mesoderm and the lower part is developing from the endoderm. Next, coming to Mullerian anomalies. These are frequently encountered in the adolescent age group. And this is the classification given by the American Society of Reproductive Medicine. So there are 7 classes. Hyperplasia, that is the first basic one. And unicornuate, didelphys, bicornuate, septate, arcuate, and DES. Diethylstilbestrol drug related, which is very rare now. Out of these, the most common is the septate uterus. So during development, the two Mullerian ducts, they fuse and the septum gets absorbed, and then we have the uterine cavity. So the septate uterus results due to failure of the absorption of that septum, and quite a more than 1 centimeter length of the septum is retained. So this is how it looks like on HSG, hysterosalpingography. And however, the septate uterus, remember, it has a normal external uterine counter. And it is the most common, like more than 50% of Mullerian anomalies are septate uterus, and it has adverse outcomes. It is associated with higher chances of pregnancy loss. So the treatment for it is hysteroscopic resection of the septum. It is septoplasty or metroplasty, which is done. Next, in the next figure, we have the bicornuate uterus. It is due to failure of fusion of both the Mullerian ducts completely. The external surface in the vagina is normal, however, in the upper part, the two ducts have not fused completely. Now, at the unicornuate uterus, it is more relevant to our topic because it has almost 30 to 40% association with renal anomalies. So unicornuate, that is on one side, there is normal development, where the other side has just failed to develop. So as we can see, there's only one side. The important, sometimes on the other side, we can have a rudimentary horn. So if there's a rudimentary horn, we have to check whether it has functional, that is active endometrial tissue. Because if there's active endometrial tissue, then there's a risk of ectopic pregnancy in that rudimentary horn. Next, uterine didelphys, di meaning two, so there's everything in two. We have 2 fallopian tubes, 2 uterus, 2 cervix, 2 vagina. And lastly, we have arcuate uterus. Now, arcuate uterus and septate uterus both are due to incomplete resorption of the septum. In septate uterus, I told you the length was more than 1 centimeter, like quite a bigger part of the septum is retained. Whereas here it is only less than 1 centimeter. So this one is actually the one with good prognosis. It does not require surgical intervention and it does not even affect pregnancy outcome as such. So this was about Mullerian anomalies. The further discussion will be done by Dr. Jaya. Thank you.
Thank you, Dr. Apurva. Dr. Jaya.
Good evening, everybody. I will be talking about the anomalies of the male genital tract, a little bit of the embryology part.
here is the relevant development of the male external genitalia. So as you can see here, these are the two urethral folds, and this is the genital swelling. So we now see that the urethral folds, they are going to close from the posterior to the anterior part. The total swelling, this genital swelling increases in size, and here the fusion of the urethral folds starts. This is the phallus part. This is the urethral groove, and this is the developing glans penis. The swelling in the anterior part is the developing glans penis. Later on, we can see the fully formed external genitalia, where we can see the scrotum, the penis, the line of fusion of the urethral folds, and the glans penis. This holds relevance ahead in the topic of hypospadias. And this part, as we can see, this is the formation of the prepuce of the penis. So it is actually formed from the reduplication of the ectoderm covering the phallus. And this is the formation of the prepuce. So I'd like to jump into the clinical part of this. The first topic that I would like to discuss is the hypospadias. So hypospadias is a urethral opening on the ventral surface of the penile shaft. The incidence is 1 in 250 male newborns. So as you can see, this is a very common thing, 1 in 250 male newborns. It may be associated with other chromosomal abnormalities, anorectal malformations, or congenital heart disease. So here we have to screen the newborn male. If we find a hypospadias, it is wise to screen the newborn for other anomalies, because this can be associated. When a karyotype is warranted, it should be done when the patient has a mid-penile or proximal hypospadias and cryptorchism together. When both of these are present, karyotyping is warranted. The ideal age for repair in a healthy infant is 6 to 12 months of age. So what if we do not refer this baby, if it comes in our NICU, and we do not refer it to a pediatric surgeon, or we do not, this anomaly by chance goes missed. So the complications of untreated hypospadias will include deformity of the urinary system. Typically what we'll see is a ventral deflection or severe splaying. We can have sexual dysfunction secondary to penile curvature, something called as cordy, which is a fibrous band which replaces the corpus spongiosum in the penis, can be seen. So that will cause painful erection or a secondary to sexual dysfunction secondary to penile curvature. Then infertility of the urethral meatus is proximal, meatal stenosis, and obviously the cosmetic disfigurement. So here we can see the type of hypospadiasis. As we discussed in the embryology part, the urethral folds are going to close from the posterior to anterior. So in that way, the anterior hypospadiasis are more common, saying the granular one and the subcoronal coronal ones. So they are the most common ones. 70% of them are anterior, less ones are posterior. So this is the granular one. This one is the coronal or the subcoronal version. And you can see there is hooded skin, foreskin. So this foreskin, so circumcision is not recommended in hypospadias, as this foreskin may be used for repair further. Then we can see a pinoscrotal one with a cordy, a perineal hypospadias, which is a rare one. Partial pinoscrotal transposition is also seen in the perineal one. This one is a rare variant called the megameatal variant of hypospadias. This may come to notice after circumcision sometimes. And this one is a complete pinoscrotal transposition with scrotal hypospadias. So the important point here is that circumcision is not advised, as we will require repair. And the other important point is to see that it is done, the repair is done from 6 to 12 months of age. And another abnormality, which is the epispadias. Here the urethra opens on the dorsum aspect of this. So in hypospadias, it was on the ventral aspect, and epispadias is, as the name suggests, epi, it is on the dorsum aspect of the penile shaft. So there are some anomalies associated with this. When one is extrophy of bladder, other is pubic diastasis, waddling gait, dorsal cordy, and in 40% cases, it can be associated with VUR. So in these three types, there are actually three types. So one is the granular type, one is the penile type, and last one is the penopubic type. So granular type we do not usually encounter incontinence, but it is in the penile and the penopubic epispadiasis that we might encounter incontinence. Surgery is required to correct the incontinence. Again, here the skin, the hood may be used for surgical repair, so that circumcision is not recommended. The next anomaly that I would like to talk about is phimosis. So phimosis is inability to retract the foreskin. This is actually physiological at birth.
So in 80% of uncircumcised males, the prepuce becomes retractable by 3 years of age. In case if this is persistent beyond 3 years, if it is physiologically persistent or if there is a pathological phimosis, the first medical management would be application of a steroid cream for 1 month that loosens this phimotic ring that we see here in 2/3 of cases. But if there is ballooning of the foreskin during voiding or phimosis beyond 10 years of age, a circumcision is recommended. So here we can see circumcision actually a modality of treatment, whereas in hypospadiasis and epispadiasis, circumcision is not usually recommended. The next anomaly is the paraphimosis. So paraphimosis occurs when the foreskin is retracted proximal to the coronal sulcus and the prepuce cannot be pulled back. Painful venous stasis in the retracted foreskin results with edema leading to severe pain. So as you can see here, there is edema and there is some venous stasis in this diagram. So the treatment includes lubricating and trying to push the phimotic ring past the coronal sulcus. In rare cases, circumcision may be needed. Here I would like to add that this paraphimosis could be an iatrogenic problem. When a child or when an adult comes to us for penile cleaning or for Foley's insertion and somebody has retracted the prepuce and has forgotten to pull back the skin, iatrogenic paraphimosis may occur. So we need to be careful about that. Then I would like to talk about another anomaly, which is the posterior urethral valve. So this is the most common cause of severe obstructive uropathy in children. Incidence is almost 1 in 8,000 males. So the mechanism here is it acts as a flap valve. So this persistent urethral valve will act as a flap valve. That means it will only allow one way when we insert a Foley's or a infant feeding tube. It will allow the tube to go in, but it will obstruct the stream of urine. So acts as a flap valve mechanism, which is important, allows catheter, but balloons are during micturition and obstructs the stream of urine. The newborn will present with palpable abdominal mass due to distended bladder, hydronephrotic kidneys, and ascites. If this is unnoticed, or the child grows up, the infant can later in life present with failure to thrive, uremia, and sepsis. If it is a lesser degree of obstruction, the child can later present in difficulty in achieving diurnal urinary continence or with an UTI. So as you can see, this is the MCU of a patient with PUB, and you can see the small anterior urethra here. There is a dilated posterior urethra. The bladder neck has become hypertrophic. The bladder has become distended. The whole bladder is thickened. There is severe VUR and there is a hydronephrosis. So what is the management of this case? So antenatal diagnosis of this can be made in the second trimester at around 18 to 24 weeks. What are the associations? See, renal parenchymal dysplasia. If this is present, this becomes the most important factor in the prognosis of this condition. There can be abnormal bladder function, oligohydramnios, and pulmonary hypoplasia. With any kidney anomaly, generally oligohydramnios or pulmonary hypoplasia. Pulmonary hypoplasia will become the most important cause of morbidity in these children. 30% of these children will have end-stage renal disease, and almost half of them, 50%, can have a VUR. So the investigation of choice here is MCU. And before anything, if we have been able to identify this in the NICU or in the PNC, a small polythene feeding tube number 5 or number 8 French is inserted in the bladder. So the bladder is decompressed. And after that, we can go for the further management. So next we check the creatinine levels. So the treatment depends on the creatinine level. So the serum creatinine level remains normal, or at least it comes back to normal after the decompression. Then the treatment of choice is transurethral ablation of these valve leaflets. But if the serum creatinine levels remain high, or the baby is sick, even after bladder decompression, we are not able to bring back the creatinine levels to normal, a vesicostomy should be considered. Now, what about the prognosis and the follow-up? So the neonatal prognosis depends on the degree of pulmonary hypoplasia and the potential for recovery. The unfavorable prognostic factors are oligohydramnios, hydronephrosis, which was diagnosed before 24 weeks of gestation, a creatinine level of more than 1 milligram per deciliter, that is after decompression, identification of cortical cyst in both kidneys, and the persistence of diurnal incontinence beyond 5 years of age. These are the unfavorable prognostic factors. What is the follow-up? So after valve ablation, antimicrobial prophylaxis is beneficial in preventing UTI.
So as UTI was discussed earlier, this is another place where we would like to start antibiotic prophylaxis. The male should be evaluated annually with a renal USG. A physical examination of somatic growth has to be examined. The BP has to be taken care of. The urine analysis should be done. We have to screen for UTI, and we have to determine this level of serum electrolytes. Now I would like to talk about the descent of testes. So this is the normal descent. The testes are formed in the posterior abdominal wall. It reaches the iliac fossa by 3rd month of gestation. It reaches the deep inguinal ring at 7th month, and it will pass through the inguinal canal normally during the 7th month. It reaches the superficial ring at 8th month, and the scrotal sac at the end of the 9 months. So as we can see, it is in the peritoneum here. Part of the peritoneum extends in like with the testes, which is called the process vaginalis. It is held to the scrotum, base of the scrotum by gubernaculum. This is later the mesonephric duct is also here, which will form the ductus deferens, and then the testes is in the scrotal sac. And this process vaginalis, it will obliterate. So that is only the remains of the process vaginalis. This forms the tunica. So the covering of the peritoneum that had come down, that will form the tunica vaginalis. This is the gubernaculum, and this is the ductus deferens. Now let's talk about defects of descent. So there are two defects. One is the ectopic testes, and one is the undescended testes, the cryptorchism. So in the ectopic testes, the most common place of the ectopic testis is at the superficial inguinal pouch. Other places of ectopic testis could be the femoral canal, in the abdominal wall, or as I said, at the superficial inguinal pouch. Now let's talk about the undescended testes. So undescended testes, at birth, approximately 4.5% of the males have undescended testes. So premature babies, as we saw, that it reaches the deep inguinal ring at 7 months, passes through the inguinal canal during 7 months, and reaches this thing scrotum by 9 months. So 30% of premature babies who are born in the 7 to 9 months of age may have undescended testes, and the incidence reduces to 3.4% at term. Half of the congenital undescended testes descend spontaneously during the first 3 months. If the testis is not descended by 4 months of life or a corrected gestational age of 6 months, it will remain undescended. So what is the importance here is the pathological changes occur in the cryptoid testes beginning at 6 to 12 months. So that is very crucial, because here the pathological changes in the testes will start happening, and at puberty, this undescended testes, if not treated, will have no viable sperm. So what is the potential consequences of this undescended testes? It is poor testicular growth. There is infertility. There is testicular malignancy. The most common type being seminoma, just 4 times greater in undescended testes. Then it can have an associated hernia. A torsion can present, and a possible psychological effect of empty scrotum. The congenital undescended testes then should be treated surgically by 9 to 15 months of age. So in short is the management part. This is taken from Nelson. So if there is unilateral palpable testes, if you can palpate it in the inguinal region, then a simple dartos pouch or chiropexy is done. If it is unilateral, not palpable, you cannot palpate it, then you can see we are not doing an USG here, we're directly going for a laparoscopy. A laparoscopy approach is taken. If we see blind ending vessels, that means there is no need of further exploration. The testis is probably absent. If it is an intra-abdominal testis, or if it is if the vessels are exiting the internal ring, then we're going to need inguinal exploration as well. After both of these exploration, we can go and further go into one of these 3 things. If it's a stage or chiropexy or an orchiectomy. If there is bilateral non-palpable testes, then we have to go for baseline gonadotrophins. There are 2 possibilities here. One is increased baseline FSH and LH. Then you have to suspect anorchia. If the FSH and LH are normal in range, then we go for an HCG stimulation, and we'll see if it is an increased testosterone or there is no response. Both of these cases, we are going to need a laparoscopic exploration. So as you can see, USGs have no role here in the management. It is laparoscopy which is the mainstay.
So these are the guidelines by the American Urological Association for the evaluation and treatment of males with undescended testes. So if it presents to us in NICU or in the PNC or any doctor who has uh, identified a male with undescended testes, what are the do's and don'ts? So you have to refer to the surgeon if there is history of cryptorchism detected at birth, who do not have spontaneous testicular descent by 6 months, that is corrected gestational age. Possibility of newly diagnosed acquired cryptorchism after 6 months of age. So one thing I would like to add here is one entity called retractile testes, which can be seen in some males after 6 months of age with hyperactive premastric reflex. Such males have to be evaluated annually. Then there is phenotypic male newborns born with bilateral non-palpable testes. We have to there will be possibility of DSD, that is sexual developmental disorders. So there we have to refer the child to a surgeon. So again, I would like to stress the point: do not perform a USG or other imaging for males with cryptorchism before referral. Imaging studies are they rarely assist in decision making, and always assess the possibility of a DSD in a case of increasing severity of hypospadias and cryptorchism. If there is hypospadias and cryptorchism, you have to assess the possibility of a DSD and do the needful. Now, the last topic that I would like to talk about is the hydrocele. The definition is accumulation of fluid in the tunica vaginalis, as had been seen in the previous slides, that the process vaginalis obliterates and the tunica vaginalis persists. So accumulation of this fluid is called hydrocele. So most common, the variety is in non-communicating one. In such cases, hydrocele fluid disappears by 1 year of age. The long-term complication of communicating hydrocele is inguinal hernia. Always palpate testes. A USG is warranted if testes is not palpable. So in hydrocele, you always go for a USG, because some children may develop a hydrocele in association with testes tumor. Hydrocele is usually resolved by 12 months of age. So it usually a non-communicating one will resolve by 1 year of age. Hydrocele persisting beyond 12 to 18 months often are communicating. So the communication is basically the process vaginalis, which remains patent, and the communication is with the abdominal cavity. So if they are persisting between 12 to 18 months of age, they are communicating and they should be repaired. So this is the diagram. This is the testes and the scrotum. And you can see in the non-communicating hydrocele, here the process vaginalis is obliterated. Here it is still persisting, and that is leading to fluid. This is one popular test called the transillumination test, where you can see that it is if it is fluid filled, it will uniformly light up brightly. And what are the other DDs of scrotal swelling in the newborn? One common one is hydrocele, another one being inguinal hernia. Testicular torsion is another one. Scrotal hematoma, testicular tumors, which are rare, meconium peritonitis, and epididymitis, which is an infective etiology. Thank you, everybody.
Thank you, Dr. Jaya.
Yes, ma'am.
If you can stop sharing, please.
Yes, ma'am.
I would like to thank all 4 of you. You have done a good job, but let us see now what we have from Dr. Dasmeet, Dr. Pragati, and of course, Dr. Srinivasan sir has joined in. Good evening, sir, and also Dr. Prajapati sir.
Good evening, madam.
Welcome, Dr.
Excellent
Srinivasan, sir.
presentation by all of them.
Thank you, sir.
Totally enjoyable. Like they should become professors in a medical college. Yeah. Very clear and this thing very well. This thing very clear. Yeah, there is no hesitation in appreciating them. That's why Dr. Yogesh asked me to come in and directly
Yes, sir.
convey it. Yeah, he sent me the link, Zoom link. Thank you so much. I enjoyed it.
Yeah.
Very important, of course. All the best.
Thank you. Dr. Dasmeet, please.
Yeah, no, at the outset, I must congratulate all of you. You've done a fabulous effort. The presentation was absolutely immaculately prepared, flawless to say the least. And Pragati, who probably must have taken up their presentations and under the guidance of Aarti ma'am, of course. So it's a wonderful effort. A tremendous amount of points which they have covered are really worth appreciating, because one thing is to just talk about the theoretical aspect, but then to end it with what is the importance of knowing the theoretical aspect, that I think they have highlighted with each condition very well. And we'll discuss a little bit more since we have a lot of time. Are there any questions which have come up in the chat box which we can answer?
Not yet.
Excuse me, Dr. Dasmit, since before your comments, I blurted out because Dr. Yogesh asked me to come in. So
No.
please excuse me for the
No, not at all,
thing,
sir.
out of this thing. But your comments were absolutely acceptable and true.
Yeah. No.
There is
Okay.
one question, Dasmeet, from Dr. Chinmay Desai. One of the presenters mentioned adenocarcinoma associated with bladder exostrophy. Is it also associated with transitional cell carcinoma?
No, the point that they highlighted why adenocarcinoma is only in a small part of the bladder where the fundus is, where the urachus gets attached. So there the epithelium has some adenocarcinoma producing the cells also. So we are always under the impression that you get transitional cell carcinoma in the entire urinary tract. But just at the fundus of the bladder, if you get a tumor, suspect adenocarcinoma. That was the point which they made. And I think that's a very good point. So where do we encounter that? In extrophy bladders, when we tubularize the bladder, try and close it. So some amount of adenocarcinoma or the epithelium there is different. So polypoidal epithelium does get incorporated over there, and that can lead to the adenocarcinoma. The other point, I think a common point which probably got overlooked or did not get stressed was an umbilical granuloma. See, an umbilical granuloma is probably the commonest presentation of urachus or the remnant of a urachus rather than the cyst or the fistula. So sometimes those umbilical granulomas, we have a simple rule like we just apply some salt application for 15 days. If it doesn't disappear, it becomes a surgical case. So, I mean, normal common salt can be applied because that doesn't destroy the skin around. So twice a day, you just ask the mother to put a little bit of salt over that redness which is seen at the umbilicus. If it doesn't disappear, then it has to be excised. And so one of the commonest causes will be some remnant of the urachus. Yeah, it's called as a raspberry tumor, as Dr. Chinmay this has indicated. So it actually looks like a raspberry has been kept at the umbilicus. So of course there can be other reasons also. There can be a remnant of the vitellointestinal tract, of the veins, of the arteries. But the commonest is the granuloma. And the granuloma, which is an infected granuloma, like the stump of the umbilicus, umbilical cord, which gets left behind. That's an infected granuloma, and that's only granulation tissue. And that invariably will go off with salt application. The minute if it doesn't go off, then you know that it is not purely granulation tissue. Then it's a granuloma, that means some congenital epithelium is remaining there, which can belong to any one of the structures which are passing at the umbilicus.
There's one more question from Dr. Manali Shinde. Do we need to monitor RFTs while starting aminoglycosides in urinary tract infection?
Yes, but generally when we start off, let's say amikacin or gentamicin, when we started off, that is on day 0 or let's call that day 0 when the antibiotics are started. But by the time we have already sent the serum creatinine, the renal functions have gone. If that renal function turns out to be normal, then after 10 days, that's the next time when we will repeat the renal function if the amikacin or the antibiotics are being continued beyond that. So after 10 days, it's very important to repeat it. So because if the renal clearance is good, generally, and if at the 10th day, again, if we have a good renal function, there's no problem, then we can just continue the antibiotic quite safely. What is important to understand is that any drug-induced renal damage will be non-oliguric renal failure at this point. So just having good output is not sufficient evidence that amicus is not causing any problem. So the minute we have a serum creatinine monitoring, then you're pretty safe. We monitor every 10th day, even if we have to give the aminoglycosides for a long period of time.
Dr. Prajapati, sir, would you like to add, please?
I think with the reference to aminoglycosides, 2 points we should remember the clinician. Number one, it is the concentration dependent antibiotic, and therefore it should be given in a single dose as an infusion, so that it works particularly so in a urinary tract infection. So that's very important. Second, as sir said, it's very important that all the nephrotoxic drug, particularly when you are having the compromised renal functions or UTI, we'll have to see for this adverse effect, particularly the nephrotoxicity. Second, even it should not be given usually more than the 2 weeks time. And suppose the condition is that you have to extend beyond 2 weeks, then the more chances that the nephrotoxicity and other problems may be there. And with that, particularly once you are giving for prolonged time, keep in mind that if there is any sign of the neuromuscular blockade, which is somehow probably we don't keep in mind, but it is known that the patient may develop some manifestations of hypotonia or even sometimes respiratory paralysis. Rarely, but it has been reported in literature. So the point is, very commonly use the drugs, but we should keep in mind how to give it, and even these the nephrotoxicity and other toxicity should be kept in mind.
Yeah, the point very well made, Dr. Prajapati. So supposing on day one when we started amikacin or any aminoglycoside, if our creatinine comes high, in that case, either we readjust the dose, the duration according to the renal function, that's a clearance. Otherwise, we can just stop it and change the antibiotic, which is safer to do. Avoid the nephrotoxic drugs in those cases.
Yes, sir.
Should I make some comments
Yes,
as a
sir.
whole generally for this topic, which has been covered very nicely?
Yes, sir, definitely.
First, I think outset definitely, as Srinivasan sir said, and all other faculties, senior people said, definitely all the 4 speakers, they require this, I would say, very loud applause. Very certainly the way in which probably they were talking, they were presenting, that was quite obvious that they are confident what they are talking. And the confidence comes only when you are very clear on your topic. And that clarity was even quite obvious. Of course, all of us know that to know and to speak and to present with the clarity is most difficult job. And somehow being, I will say, the junior persons, they have done the good job. And as Sir Srinivasan sir said, probably their future should be very bright from the academic point of view. Coming to the topic, when we were students, the teaching was from the embryology, then the anatomy, and then the physiology and further. I think that was a very clear concept, and more so particularly the topic which we have selected today for the discussion. Unless probably you are clear regarding the embryology, we may not be able to understand what's an anomaly or how it develops. So I think it's very appropriately, and that too, that embryology somehow considered the boring topic. So speakers have taken care not to bore, but to at least important points, to at least revise us and to give us that how it develops the malformation. They have taken, I will say, utmost care, and that is really very important. Even one more point I would like to appreciate, which I observed from the beginning. I think with the first speaker, sorry, I may not be able to name of all the speakers, all the students, but I'm sure that probably the first speaker was Dr. Sailusha, because her name is seen constantly over the screen, and she was there. That the pronephrons, mesonephron, and the metanephrons. They are not the nephrons. I have heard even the topmost nephrologists talking that the pronephrons and the mesonephrons, they are not nephrons. The nephrons are in the future when they are the formed properly. So I think they have taken care, absolutely even keeping in mind. Regarding one, I think certain points which I have noted just for the students and probably may be helpful in our practice also to keep in mind. That is regarding any renal malformation or when severe malformation, and when we are submitting the child for the surgery, usually in the presence of pediatric surgeons or Dasmisi, I am taking the liberty. They may say that the results will be good, but I think as a physician, we should keep in mind in most of such conditions, results are depending upon the lung hypoplasia. So always keep in mind severe renal malformations I'm talking, not the mild, which may be corrected, but severe malformations, or particularly when you're operating the child in the newborn period or infancy, that early part of infancy. Even the congenital diaphragmatic hernia, the surgery does not depend that how much the lesion or this hernia is there, but depends on how much the lung is hypoplastic. Ultimately, post-operatively, patient may not develop the complications of surgery, but patient will develop the complications of hypoplasia of the lung. So I think that's very important for the physician, surgeon to understand and to give at least the prognosis to the parents regarding the surgery. So that's a very important point. All of us know that following the ultrasonography, which was not available when we were students, probably we were not knowing what is antenatal hydronephrosis. But with the availability of the facility, and that is the contribution of the advancement of the technology, that we came to know to detect even before the baby is born. And even the guidelines have come very nicely, I will say, interpreted. And some of the questions of MT or DNB examination, antenatal hydronephrosis, maybe the short note, maybe even the full question sometimes, or even the genital malformations. Some examiner may put the general title, but these are the knowns. And anterior hydronephrosis, it is sometimes the overdiagnosed, because the exactly depends on the clarity of the interpreter, sonographically how is interpreting, and as a clinician how ultimately you take it. So I think it's a just point which I wanted to convey, that best way is to follow exactly the guidelines, because they have prepared the very good guidelines, rather than just to go personal, I will say, impression or some bias or something like that. Because I have seen in the practice, I think all of us must have seen that sometimes you are over considered also, and if you follow even, they may not require the intervention, and here intervention is required. We should not be late also. So I think it's a very crucial point which all of us should know. I think particularly for the students, even multicystic kidney and polycystic kidney both are quite different conditions. And if we try to understand the embryology, multicystic kidney is an example of malformation. That there is a problem with the excretory component and the collecting system, and that results in the multicystic kidney. While polycystic kidney is an inheritance disorder, and here not only the kidneys, other organs are also commonly involved. Maybe the liver problem, maybe the spleen problem, maybe the other places. So I think both the situations are different, and then therefore even the workup and interpretation and even the management will be quite different. I think very important, which I want to know as a general pediatrician or to the students. Many a times anomalies, suppose ultrasound or something antenatally done and you are knowing it's all right. But many of our patients are brought in the OPD for some other complaint. They are never complained of the malformation or anything. But I think there are some markers clinically that we should note it. And that that suppose the preauricular skin tag, and that is the common association with the renal malformation. Similarly, polydactyly and syndactyly. I've seen the one family, one child, then I saw a mother is also having. Then mother says that my other daughter is also having, and 4 or 5 members in the family. We investigated all. Out of 5, 3 had the renal malformations. He had the renal malformation. I have even preserved that picture also with the renal malformation and even the clinical markers. They never complained. They were not brought for the renal problem, but later on, how retrospectively we found. Similarly, you know that if you get something at the back, in the top hair or something, and maybe related with these issues, neurogenic condition. And similarly, you know, we pediatricians not accustomed to measure the blood pressure. I think that's the greatest fallacy. So I think that we'll have to measure. And sometimes this hypertension only may be the manifestation of malformation of renal thing. Later on workup, you know, you come to know that, oh, this hypertension was due to this problem, or anemia was due to this chronic renal malformation. And you know, we are learning from our adult friend physicians, nephrologists, that some conditions were missing in the children, and later on they are detecting the adults with the major issues, the end stage renal disease or something, or hypertension. So I think that's our prime duty to keep in mind that these markers are there, and that markers we should not miss it. So that's another thing which I was talking. Anything with the reference to sir was talking regarding this umbilical granuloma and the urachus. With that is my question to the students, that what should be the length of the umbilical cord in the newborn when you are cutting the cord? How much the length should be kept? Any student? I think this should be the viva question. Many times even examiners are asking.
Yeah, he is keeping in mind urachus.
Yeah, you know the length, because if you are, I will say, cutting with the too short cut, it is possible that urachus may be there and the fistula will develop, or even Meckel's diverticulum, and then the fistula will develop. And to avoid this, at least 5 centimeters should be the length of the umbilical cord. This is the standard guideline to avoid these problems or complications. So I think these are the small points, but I'm sure that it helps a lot. And
just in line with that, sir, if I may interject. So it's very important to see that the base of the cord, where it just is attached to the umbilicus, if it feels bulky, then you go even further. Then you don't stick 5 centimeters. You go further, because there can be an example as minor, which can be associated. So you don't want to clamp on the bowel or any other tissue which is there. So you go even further. So if it is like looking like a normal size cord throughout, in that case, then 5 centimeters root is a good root. Yes.
As sir said it very rightly, it is so. I say it's a good clinician's observation. As sir said, routinely will keep 5 centimeters. But suppose this type of observation, where even the exophalus is possible, in that case, one still go for the more length of the umbilical cord, so that at least less problems of damage, or even the you have the good chances of good surgery also. Very rightly, I think the one student said, I would like to emphasize, and all the practitioners, please listen. Whenever you plan for the circumcision, see that there is no hypospadias. I have seen the child 9 years with the hypospadias, already surgeon had done the circumcision. And nowadays, you know, it's a crime. I am not sure, probably it may be punishable to us, because, you know, the same skin can be used very nicely by the plastic surgeon to reconstruct the urethra. So I think this is very important message. I think she spoke even 1 or 2 times, and I understood that she has very strongly this understanding and to convey this point to our point, but I thought that let me go for that. Another similarly, phimosis. Why there is physiological phimosis? Why there is physiological phimosis? Anybody, any student? And again, this question can be the viva, newborn. You know, you are going to get the one newborn.
Very important question, sir.
Whether
you will do circumcision or not.
Yeah, and nature has whatever is provided with absolutely understanding. The only thing that we should understand. You know, physiological phimosis particularly kept provision by the nature, that infancy, the child is many a times, particularly below 6 months, in the lying down position. And during that time, the child is passing urine, that urine will fall around this perineal and even the inner aspect of thigh. And you know, urine contains ammonia. Therefore, child will develop the persistent ammonical dermatitis. To prevent it, nature has provided phimosis. So some tubular structure, urine goes away. And I think when examination of the newborn, you must have seen that always either the urine will be on the wall or upon your apron, but nowhere else, not at least on the baby. And nature has provided this, and therefore this physiological phimosis is there, and that should not be. So tell our friends, surgeon, that please, if I find the problem, later on I will come to you. Even how exactly you should define this phimosis. Not just trying to retract,
Yeah.
skin is not retractile. How will you? And for that reason, it is said, I'm learning from sir like pediatric surgeons, that when you are uplifting this preputial skin, then if you're able to see the external urethral meatus, I think it's sufficient. Don't consider the phimosis. And second, very nicely, somebody was telling that while the child is passing the urine and there is a really bulbous swelling, that means urine is collected over that part. Probably that indicates that it's a tight preputial skin, which may require some intervention, which may be the circumcision or mild intervention. So I think that's another point that very commonly we are keeping in mind, so that we should see. Many times I think for the physician, because mother is very keen, she is going to ask every time, retractile testes and undescended testes. And that how, simply look at the scrotum. Empty scrotum is not well developed. And that definitely, probably it conveys you that this is a definitely undescended testis. Retractile testis in between, at some time it comes in the scrotum. And therefore the scrotum is at least well developed. But in the undescended testis, just if you look at the scrotum, it shows quite obvious that, oh, it's not well developed. And later on, you can go for in the squatting posture, even you can go for the milking before you go for this, I would say. But nowadays we have the good sonologists. But sonologists also will do in the lying down position. And each probe even will cause the retractile testis, and but simply I will say for the physician, that is very important. And
so can I just interject
please,
on
sir.
2 points?
Yes, sir, please.
So first is about the phimosis, and then I'll come to the undescended testes, the retractile part. Phimosis, basically, nature has designed the prepuce to cover the glans. And the way nature has designed it, it is not supposed to go back till such a time that the child reaches puberty. That is actually nature's design. So it's only at puberty that the skin is actually supposed to go back. But people are in a bit of a hurry. I've seen most of the phimosis, the surgical cases that we get, are the ones who have been, who come to us because of the grandmothers and those traditional dyes who used to come to bathe the babies. They have a habit of putting some oil over the prepuce and trying to retract the prepuce. It is something which should be absolutely condemned, because that leads to circular tears of the preputial ring, and that actually causes the pathological phimosis. So that is a practice which should never be done. At the most, the only way to clean it is you just retract the prepuce gently and clean with plain water. Don't use any chemical, no oil, no soap, nothing. So just plain warm water with a soft hand, just clean the preputial ring, the terminal portion, and that's it. So there's no phimosis. And then in case there is phimosis, you give a short trial of steroid application only in those cases where you don't see any whiteness, no whiteness which comes over there. So that is something like a xerotica balanitis obliterans or BXO. So that tissue becomes absolutely fibrotic. So the minute you see fibrotic, the steroid has absolutely no role to play in those cases, and those cases directly should be circumcised. Then coming to the point of, I think somebody has put in the chat box, I've forgotten what that point was regarding circumcision. But coming to the point of retractile testes, the scrotal development is not purely because of, it was thought that it is purely because of the testes descending into it. But the scrotal development is also hormonal. So sometimes you can get undescended testes with a very well-formed scrotum. And sometimes even in retractile testes, sometimes the scrotum does not get well-formed. So it is some kind of a hormonal defect which is mediated by dihydrotestosterone, which regulates the local genital development. So the best time to examine for retractile testes. What is the best time to examine for retractile testes? I won't ask the question because they will not know. It's the first 3 months of life.
Yeah.
In the first 3 months, the cremasteric reflex is absent. And it becomes absent after puberty again. So when you want to find retractile testes before 3 months and after puberty, you should not have retractile testes, because that is how naturally it should be. In between, the patient can have retractile. Now, how do you differentiate retractile from undescended? You can ask the mother or the parents to give a warm bath.
Warm water.
Yeah, warm water bath. And with that, the testes, the cremaster relaxes and the testes comes down to the bottom of the scrotum. Second way is when we are examining the child, you do a milking test. So you start by compressing your fingers just near the anterior iliac spine, and you touch the pubic bone posteriorly, and then just go on milking it towards the pubic tubercle, ipsilateral pubic tubercle. If there is an undescended testis, the cremaster gets compressed so much that cremaster just relaxes and the testis will come down to the scrotum. And then with the other hand, you can then try and feel that testis. And when you try and pull the testis down to the bottom of the scrotum, it should come easily. And if you release it, generally it would remain there. But if you're having to pull it very hard, or you're getting that tugging kind of a sensation, the testis is getting pulled by the body back, then you know, okay, that is actually falling in the category of undescended testes and not a retractile testis. It's very important to differentiate the two. And even in retractile testes, even if you assume that they are retractile or you have diagnosed that they are retractile, yet one yearly examination is very, very important. Because sometimes the retractile testes, they get converted into an undescended testes as the processive vaginalis gets absorbed or the cremaster becomes stronger. The whole idea is that the testes should reside at the bottom of the scrotum. But if most of the time the testes is residing somewhere near the superficial inguinal pouch or within the inguinal canal, as would happen with a very severe variety of retractile testes, then the testes starts shrinking. And if you find a difference in the size, not on ultrasound, clinically, because ultrasound most of the time is wrong. Even yesterday, I had a case in the OPD where the ultrasound had diagnosed undescended testes, and the patient came panicking. And actually, the child only had retractile testes. So ultrasound will only show where the testes are located at that point of time. It doesn't give you the dynamic picture of what is happening over the entire day or over the entire month. But if the testes starts reducing in size, you know that most of the time it is residing in a non-scrotal position. Those testes, even if they are thought to be retractile, will need to be fixed. So the whole idea is to be more proactive in such cases. A third point which you mentioned, I think it started off from the ligation of the umbilical cord. Whenever a child is born, I think in all the places where neonatology is a very strong point, a head-to-toe examination is done at birth. Yeah, head to toe, look for all any sinus, any swelling anywhere, anteriorly, posteriorly. Lift up the arms, examine the anus. Try and put in a feeding tube into the anus. Ideally, we would recommend a 10-number simple rubber catheter, but that's not very easily available everywhere. So first, you pass the catheter into the esophagus. If it goes more than 8 centimeters, you know that there's no esophageal atresia. The same catheter can be used and passed per rectally. And if it goes inside, and it comes stained with meconium, okay, meconium has come down. So a lot of abnormalities get sorted right at birth. In case the patient has not been examined at birth by a pediatrician or a neonatologist, whenever you see the patient as a pediatrician, you see the patient for the first time, don't forget to do the head-to-toe examination. So where most of the conditions can be sorted out and diagnosed early. It should not be that so many years I've been going to so-and-so pediatrician and this hernia is present and I was never told. And I had pointed out also, many times it happens in busy practice. You say, okay, it doesn't matter. The parents say, okay, there's some swelling over there. They say, okay, we'll see about it later. And then the patient lands up with some kind of obstructed hernia. So that should not happen. So either if you have not examined it, you take help from a pediatric surgical colleague. Ask them, at least ek baar aap dekh lo ye patient ko. or otherwise head-to-toe examination, I think is a very, very important thing. And with the basic functions, that I think everybody, all pediatricians never miss out on that, the basic functions. आपके खाना खा रहा है कि नहीं, weight बढ़ रहा है कि नहीं, urine stools properly हो रहे हैं कि नहीं. So that I think nobody misses. But things like preauricular sinus, things like thyroglossal cyst, and or something like branchial fistula, or swelling at the back. You did mention about that spina bifida occulta, tuft of hair, or you find a small swelling somewhere in the midline. These should never get missed. Undescended testes, hypospadias or epispadias. There are some things which patients are going to be complaining of, like extrophy, so they will come complaining of it. But something like a hypospadia, they may not know that there's some abnormality there. And in that case, then if they have not noticed, and if the pediatrician picks it up, it's so much better. Your connect with that patient and their family becomes so much better, because you have picked it up and you have informed them that this needs to be rectified. So these are the essential points which I wanted to point out without going into specifics of any disease process as yet. We can discuss it more. I think there are some.
There's one question in the chat box. Dr. Shatakshi Garg has asked, can undescended testes be corrected after 6 months of age if there is some underlying health problem which does not give fitness for surgery? Or sometimes patient presents very late, like beyond 6 months, 1 year.
Yeah, no, that's a very valid point. There are recommendations. We follow the recommendation. Okay, by 6 months, or rather at 6 months, you wait for the LH surge, which happens at 4 months of age. So you wait for that. Whatever little bit the testis descends secondary to that, you allow that to descend, and then re-examine the patient. And if it has not descended to the bottom of the scrotum by 6 months in a high scrotal, inguinal, superficial inguinal pouch, or abdominal position, the time has come to correct that surgically. The more we wait, the more are the chances of the testes becoming secondarily dysplastic. So first of all, we have to remember that if the patient has undescended testes, the testes primarily developed as a dysplastic testes. And since being a spectrum, they may be very mildly dysplastic, which may not cause any functional long-term impairment. But the secondary dysplasia which happens because of the high temperature it is subjected to. The higher the test is, more the temperature it is being subjected to. And that secondary dysplasia, if you can imagine that in abdominal testes, at the end of 2 years, 6 months is again the recommended period when they should be tackled. At the end of 2 years, 80% of the abdominal testes would have lost their entire quota of germ cells. 80%. So that's the importance of intervening on time. The more we wait, the worse the prognosis as far as the infertility or the complication of undescended testes are concerned.
So I think what sir mentioned in all this situation, that clinical examination by the primary physician is very, very important. I think that is the point to be really should be emphasized. Somehow we are even emphasizing, but in the practice, that part is lacking. Let me even see some of the examples which I have seen. In 1 year in my practice, I remember a few years back, there were some 12 or 13 hypospadias in 1 year. And then we say that that can be the epidemic of measles, but cannot be the epidemic of hypospadias. So the point is probably examination of the genitals should be routinely somehow, and more so in the children, that is the younger children. Let me even give an example, probably may take a minute or so. Almost 15 years back when I was in the LG hospital, municipal hospital, about 7-8 years old child came with some minor respiratory infections. My registrar opposite to me was sitting and she was examining. Just that attendant was insisting that senior person should see. So she wanted that I should see. And she was, I will say, explaining 2-3 times that Dr. Chawla, that she said that, okay, it's my problem. Already your child is going to recover. But I was watching that she is not happy. Then I said, Dr. Chawla, let me see the child, take on the table. Madam, believe me, when I examined, that was simple upper respiratory infection, nothing else. But any child, I will not miss to examine the blood pressure and even this genital. 7 years old child was having the undescended testes. And believe me, when I was talking to the attendant, female attendant, I was thinking that she's mother. She said, no, I am Masi. And child is staying at Surat. Then I said, I will give the note and send this note to parents. Madam, believe me, on further, I would say interrogation or talking to the lady, I came to know the father is the general surgeon of the city. General surgeon of the city. This was almost 15 to 20 years back. I said that now I will not write down the cheat. I would like to talk to him. Why I am giving this example, to be very frank, this is the extreme of it. And I think as a pediatrician, this is, I think when, as sir was talking, when we were student, the undescended testes should be treated surgically after 5 to 7 years, we were taught. Then it came down that before 5 years. Then it came down, and what sir explained everything, that why this specific age is defined, not even too early, you are very specific that after these 15 months or so. So I think that we'll have to understand it in an appropriate terminology. Second thing, many a times mother or the parents, they are showing that the size of the penis is small for that child. Many times it's a buried span, particularly if the chubby child is there. And just if you measure it in stretch, penile length, and if you explain them, then this is the biggest problem for the parents or grandparents. Many times they are worrying, which means say, oh, it's all right, it's normal. Very loosely we are answering, but if you go in the details, probably they will be convinced. One child, I remember it was Sunday, excessive crying, already 2 consultant has seen for infantile colic or so, about 2 years old child. Somehow child was brought to me. And again, why I'm insisting that this is the beauty of the examination of the baby. Already infantile colic or acute otitis media, considering medicines are prescribed for the excessive crying. When I examined, that was the torsion of the testis. And I remember that pediatric surgeon later on called me that, sir, I have taken the liberty. There were such mild changes, but it was possible that these it should be revived totally. And I explained the parent that I'm not going for the arachidectomy. I will say, by chance, if there is further problem, I may have to go. But fortunately, the testis was safe. So I think just to example to emphasize that examination is very, very important, which probably we should not miss. Several points are there, but I'm sure that
Dr. Srinivasan sir was raising his hand.
Yeah, again at the end from my side.
You'll be surprised to know. One of my 2 years junior, when I was doing my DCH, he was a senior surgeon. So he's, of course, I don't want to mention the name. He did MD later, but unfortunately, he died of cancer, carcinoma of the testis. He had undescended testis. So a doctor who has been doing MBBS in JIPMER, a brilliant student, and then subsequently he got MD seat also on merit. But unfortunately, so similarly, torsion testis we have seen. One child, was the biliary lymphadenitis, that's what this thing was treated, but came very late, and by the time it had become gangrenous and he lost the testis. So whenever you find, it's very important that you keep your mind open and examine thoroughly. And any doubt, immediately you must consult as immediate senior. So this is a real incident which I wanted to tell. Okay, just imagine a valuable life, a brilliant, and of course we have got a medal in his name. That is best MD medicine. There is a medal in his name.
So moving away from thorough clinical examination, there was one point which I wanted to highlight was the concept of nadir creatinine. When we are talking about posterior arterial valves or any bilateral renal affliction, there is a proper nomogram. I think you mentioned 1 milligram % as normal creatinine. Okay, that would be applicable only in adults. 1 or 1.5 is applicable only in adults. In pediatric age group, especially the age group that we are concentrating on, the posterolateral valve, patient presenting with UTI, anything more than 0.5 milligram percent is abnormal. 0.6 is abnormal. Just remember that. And that's very, very important because how proactively we have to treat that patient. The first thing would be catheterize. If not necessary, the catheter can be taken out later. The first thing would be just catheterize because we want to decompress the system. The minute you have hydronephrosis, hydroureteronephrosis, patient is presented with urosepsis. The minute creatinine is raised, catheterization is compulsory. Or the symptom is such, patient is presented with pyuria, there's pus in the urine. Catheterize. The first thing you have to do is catheterize, and with full aseptic precautions. So that is a very, very important part of management. And then subsequently, as the investigations come, your antibiotics start acting, etc., the remaining plans can be made later. But this is a very, very important part which often gets missed, is of catheterization at the right time. So first, that becomes like an emergency. You just have to get the UTI under control. If there's pyuria, if the urine is coming out like pus, not just catheterization, we give diluted povidone iodine bladder washouts also. You take 5 ml of povidone iodine and add 45 ml of normal saline to that, and they instill it into the bladder. Instill 10 ml, drain it out. Instill, drain it out, and till such a time that the returning fluid is the same as the same color as the instilled fluid. That's very, very important. So this is a bladder washout, which is very, very important to give in patients who present with pyuria. And so these two are very, very important points, the serum creatinine and the catheterization. Never omit that.
Dr. Pragati, we are coming to an end. It's almost nearing 8 o'clock. It has passed very quickly. I think we can go on and on. But Dr. Pragati, would you like to add anything as some messages, end messages before we?
Dr. Prakriti herself looks like a student, so young, but she has trained them so well. So really brilliant. Yeah.
Can you unmute yourself, Pragati?
Yes, ma'am.
Yes, please.
Ma'am, some take-home messages at the end of this presentation are that since fetal urogenital abnormalities are a significant cause of neonatal and childhood mortality and morbidity, so ultrasound assessment of these babies throughout the pregnancy continues to be the most important source of clinical information in evaluation and monitoring of the urogenital disorders. Also, Prajapati sir and Dashmit Singh sir have already said the importance of clinical examination, general examination of a newborn at birth, subtle signs like presence of occult spinal dystrophism or having preauricular tags, preauricular sinuses, ear anomalies should not be missed. And early signs of chronic kidney disease, which we can see in the OPD, like short statures, undiagnosed anemias, hypertensions, and abnormal streams of urine should be investigated. First episode of a urinary tract infection in a male child should always be taken seriously as compared to that of a female child. Any abnormal palpable mass, presentation in the newborn period of urosepsis should also be taken very seriously and should be investigated. A child having failure to thrive in the infancy or in the early neonatal early period should also be investigated for chronic kidney disease. And any pyrexia of unknown origin, we should never forget to do a urinary examination to rule out a urinary tract infection. Rest of the things, ma'am, sir has already discussed in detail.
Just one point, that those people who attend deliveries and who are working in labor room, never forget the cut umbilical cord, because that is the only time when you can identify 3 vessels.
Single umbilical artery.
There is a single umbilical artery. It is associated with renal anomalies. Once it is all shriveled up, you will never know how many vessels there are, and you will have to wait till the patient becomes symptomatic with a kidney problem. So I think Prajapati sir has got something to say.
Just madam, with that reference, that I am learning from some of the neonatologists that their performer because neonatologists are attending this newborn call, that in that performer they have mentioned the numbers of umbilical arteries that they will have to put on the record.
Yes.
I think it's a good habit that when you attended that call and you cut the cord, see that how many umbilical arteries were there. So I think, gradually we are learning, and I'm sure that as Madam insisted that this is a good, I would say, routine part of our assessment that and single umbilical artery, so many things you can go and get it. Thank you, Madam.
One point I want to make, during our days of house agency, we have to even see the placenta, weight of the placenta and examine the placenta also besides the umbilical artery. But nowadays, I think that habit has
That time has gone,
died
sir.
down. Yeah.
So right.
Okay, so I think we are nearing almost exactly 8 o'clock, and I have to hand over to, no, Pravyapati sir wants to say something.
No, just
One
I
more
think
minute.
before you go for the wind up,
Yes.
once more let me appreciate the whole, I would say, department, BJMC, head and led by Madam Dr. Aarti, and even this mentor, Dr. Pragati, and all the four, I will say, students, those who were the real, I will say, speaker rather than just these participant or these presenters. They have done the very good job, and I think that's even the illustration for other students. That should be in our mind that once it is opportunity for me or I accepted, I will go with the full preparations. I will go for even the requires multiple rehearsals. But when I'm talking, I'm presenting, I think it should be very clear. I think if you come with these ideas and if you prepare in this way, I'm sure that it can be best. Let me just give an example. In probably 1985 or 6, I was attending this nephrology CME in All India Institution at New Delhi. And one speaker was there discussing histopathology in the details of renal histopathology. I was impressed by the person, and I was talking to my colleague who was nearby sitting that this must be the senior person and he must have done lots of work on this renal biopsy and histopathology. Next was Dr. Srivastava, and he listened to me, Dr. R.N. Srivastava, and he said, no, Dr. Prajapati, he is just senior resident of Maulana Azad. He had just passed the MD pediatrics 1 year back. And he was talking as if some senior person was talking. And from that, I learned even seen that even the junior persons are also having that capability. The only thing that the teachers like Madam will have to bring it out. And this is very important job of the teacher, not just to speak or to give some lecture or preparing from the Nelson. This is the great job of the teacher, that identify the capability of the student, give them the opportunity, even push them for the good preparations and for these multiple presentations. Thank you very much. Sorry, I've taken the little bit liberty, but I thought it is very, very important. Thank you very much. Over to you, Madam.
I want to thank everyone who is here on the screen, and there are others who are off the screen listening. And it has been really very informative, encouraging, and I think the students and the mentor is very happy about all your praises which are there in the chat box. And of course, Dr. Dasmeet giving all his inputs. Being a busy surgeon, he's still sitting here. I'm wondering how many missed calls he has got on his mobile. So he
Just
will
a few.
attend to it the whole night now.
All need a standing ovation.
Yes, thank you. I will thank Dr. Yogesh Parekh sir for giving us this opportunity, and I'll hand over to Dr. Nehal to do the concluding remarks, please.
Thank you so much. At the outset, when we thought that we will start with this seminar this time, it was Aarti madam who immediately agreed to the idea. And for that, madam, thank you so much. I must say, all the 4 residents, all the R3, they are so much prepared that even if we don't have expert, though having expert is definitely a crown on the head, but they were prepared to answer even our questions. So they are presenters and they were the experts like. So congratulations to all the residents and also their mentor. And thank you so much, Aarti ma'am. So, special thanks to our expert today, Dasmeet sir. Your comments were really very nice. It cleared so many confusions, and like in my mind also there were many confusions. But before I ask any question, sir already clears it out. So many confusions which are cleared by even Baldev sir and Dasmeet sir. Thank you so much, sir. So with this, we can end our session for today. We will meet for the next Saturday. Thank you so much.
Okay.
Thank you very much, madam.
Good
Thank you
night,
very
everyone.
Thank you. Thank you.
Good night.
Very well conceived and very well conducted. Thank you so much, all of you.
Thank you,
Thank you
Doctor.
all for
Thank you.
sharing your valuable insights. We are more than grateful to everyone present here. We hope to have you again at our platform very soon for the next session.
Thank you so much for
Thank you.
Everyone.
Thank you.
With
providing
all
this.
this permission, we are signing off the session over here.
Yes,
Please,
yes.
please prepare the flyer before
Only.
the madam asks.
Yeah, because Ankana, you give me tension when you don't send that flyer.
Yeah. So please prepare that link and the flyer before it. So
Then
we
I
will
have to
circulate.
trouble Dr. Yogesh sir कि अभी
Yeah,
तक आया नहीं flyer करके. So how can it fly then? So
Yeah.
next time give it to us in advance. All
Okay,
right.
sure, ma'am.
Yeah.
We will do
Thank
it
you.
from next time. Thank you so much, ma'am. Good
Thank
night.
you. Good night.
Good
Good
night,
night.
everyone.
Good night.
And nice to see you, Dr. Pragati, and all the residents.